We've survived and we've thrived through many changes in the healthcare environment. Who here remembers when the world was supposed to end with Medicare? There's a few of you here who probably remember that, Randy. Yes. Then the world was supposed to end with HMOs, and now the world is going to be ending with corporate medicine and alternative practice models. Maybe. So we're faced now with a new set of challenges and opportunities that are both extrinsic and intrinsic to our PM&R home. From the outside, the adoption of the Affordable Care Act in 2010 is requiring us to look at medicine through a different prism. This has been characterized by the Institute for Healthcare Improvement as the triple aim: improving the patient experience, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. What specifically does this mean for physiatry, and what has your academy been grappling with in order to translate these aims and goals for our practice? First, we've been trying to develop a workable and meaningful ways for our members to document and improve quality and effectiveness. We've been seeking out and devising ways of meeting the reporting requirements and measuring outcomes. In the short run, with the PQRS, or the Physician Quality Reporting System that's currently in place, but now we are really looking forward to bigger changes that will happen in 2016 and 2017. How are we going to interface with the requirements for the Merit-Based Payment Incentive System, or MIPS? Or alternatively, how are we going to participate in alternative models of payment in healthcare? At this time, a group led by Gwen Soa and Daryl Kalin is exploring the implementation of a patient data registry that initially will be focused on spine care, but that we hope will be expanded to other populations in the future. For any of you that have participated in big data collection and use, you know that this is going to be a very complex and expensive task, trying to find a way to build registries that will allow participation by physiatrists at every site and at every level of practice that will answer the questions of quality and clinical improvement. Will registries allow us to improve the quality and cost for such common health conditions as back pain and arthritis? We think that as physiatrists, we can make a significant difference in the direction of musculoskeletal care, but it will take leadership, and it will take a willingness to look critically at how we implement paths of care and how we use procedures to do so. How will we become leaders and participants in alternative models of healthcare with musculoskeletal care, pain, cancer, geriatrics? How are we going to thrive in the post-acute world with the initiation of accountable care networks and organizations? As we know, post-acute services are a pretty easy target for cost reductions. As we also know, there is abuse of post-acute services, and there is a lack of oversight for many of those services. How are we as physiatrists going to respond to questions of restructuring? Will we retreat, or do we move forward as leaders in evaluating and transitioning patients who have real needs for rehabilitation treatment? Do we allow the medical system to achieve cost savings with across-the-board cuts for rehabilitation and allied services? Or do we step forward to direct the effective use and deployment of personnel and technologies? Peter Esselman and Stu Glassman are leading the analysis of how physiatrists can adapt themselves and their environments to ensure optimal patient care and outcomes. How do we move forward in decision-making with such a rapidly changing healthcare environment? Well, Jim Atchison and Randy Black-Schaefer have been leading a pilot process to do rapid, in-depth analysis of physiatric practice in the key areas of spine care and stroke. The findings of these committees have resulted in some truly important insights for our specialty that are now directing our efforts to model care pathways, to engage with other medical specialties, and even to alter graduate medical education. Any and all of these initiatives will demand new levels of leadership and entrepreneurial activity from all of us. It's not going to be practice as usual. What's been happening internally for our specialty? Your Academy volunteers and staff, particularly Michelle Gittler and Andre Panagos, have been trying to make sure that you are operating at the forward edge of healthcare and new practice changes throughout educational formats and topics where you will see innovations in today and over the coming year. We've been carefully examining how to serve our members more completely. You will notice during this meeting more opportunities today and this week and over the coming year for our youngest members to help them in career development. And as you all know, we've been in deep discussion over the past year regarding our members' concerns about the process of maintenance of certification, communicating this concern to the American Board of Physical Medicine and Rehabilitation. The Academy supports having our specialty develop its own surveillance of knowledge and competence, but expressed our members' dissatisfaction with the path that had put into place. However, I'm very happy to report that your Academy leaders and the American Board of Physical Medicine and Rehabilitation have inaugurated a joint task force to develop a shared vision and shared ideas for models to implement that vision in education and in quality. And finally, your Academy representatives continue to work on how to integrate all the members of our rich and varied specialty who care for those from 6 to 60, from youth sports teams to elder athletes, from those with concussion to those in coma, from those with back pain to those with paralysis. Despite our differences in practice, we are a specialty with a common focus on the patient in their own environment with their own unique needs and their ability to function at the highest level possible. We need to become heroes for PM&R and for our patients. It really is up to you and to you and to you to make the best outcomes happen and be active in your institution, in your community, and in the Academy. It won't happen without you. There's a great philosopher who recently left us named Yogi Berra, and he said, if you don't know where you're going, you'll end someplace else. So listen, have a great meeting, learn a lot, go out and do good, and be a leader. Thank you.